My name is Stacy Lindau. I'm a professor and physician here at the University of Chicago. My passion is engineering solutions to injustice. This is what gets me out of bed every day. I believe that we can solve injustices by working together with people who know injustice best. So most of my work involves collaboration, either with people from the surrounding communities that we serve or even my own patients. I'm a gynecologist, and one of my areas of expertise and interest is female sexuality. I've been particularly interested in how we as a society understand sexuality in the context of aging or across the life course. We don't know as much as we need to know about sexuality, especially female sexuality, and we know even less about sexuality in the context of aging. In my clinical practice, I use my skills as a gynecologist and evidence from the science we and others in the field do to help women with cancer preserve and recover their sexual function as they recover from their cancer treatment. This effort, in partnership with our patients who are acting as advocates, has led us to think about how we amplify our knowledge and our voices. I can only see one patient at a time, one publication at a time, and yet there are literally millions, if not hundreds of millions of women on the planet Earth who deserve and need to know some of the basic things we've come to understand about women's sexuality. So WomanLab is a new platform. We're experimenting with how best to communicate what we know to the public. But this platform aims to ensure that every woman and everybody who loves and cares for women know what they need to know in order to preserve and recover sexual function. So medicine obviously is a big word and it means different things to different people. I was interested in everything, and when it comes time for residency training, we have to make a choice. Obstetrics and gynecology appealed to me because it at least allowed me to focus on half the population, the one I sort of knew best just by virtue of being a woman myself. It also involved training both as a physician and as a surgeon. And it requires an understanding from the earliest moment of life, the developing embryo and fetus, all the way to the end of life. So I chose obstetrics and gynecology. Within that field, I took an interest in questions patients were asking about their sexuality. If I have this hysterectomy, will it affect my sexual function? If you remove my ovaries, what will that do? And what I realized in attempting to answer patients' questions, we just had very limited, surprisingly little evidence to answer some of these most fundamental questions. That seemed unfair to me. And I saw a lot of suffering among women who had their sexual organs removed in order to treat cancer, but who were left with no information, no guidance or counseling about what this might mean for their future sexual functioning. That injustice intrigued me, it made me angry. It seemed like a pretty simple problem to solve, and it has become a focus for my life's work. But the theme of injustice is one that motivates me. And my work also focuses on injustices that impede the health of people on the lower end of the income spectrum. So that's the tie that binds my work together. To have a passion around engineering solutions to injustice necessitates collaboration across disciplines. I've never been a person with a hammer looking for a nail. I'm really attracted to a certain kind of problem, really problems that Ralph Ellison, the novelist, called invisible. Invisible is what we can't see because of the physical limitations of our eyes. We need a microscope, a telescope, an MRI to see. And science, especially biomedical science, has been heavily focused on the invisible. I'm intrigued by the invisible, which is what we don't see because we choose not to look down there. This is a problem in gynecology and in taking care of women. In our city, in Chicago, choosing not to look down there might be really looking at the South Side and thinking about how the biases we have about higher poverty communities or communities of color influence how we see. So those questions of invisibility have required me to build collaborations with social scientists across disciplines. My lab currently is working with systems scientists at Argonne National Labs, because we've come to understand that the interventions that we can develop to address injustice tend to be more information-based interventions than medicine or device-based interventions. And what's really interesting about the difference is that information can spread from doctor to patient to family member to coworker, whereas a defibrillator can. So we need to collaborate, in this case, with the system scientist to understand how an intervention from doctor to a primary agent can spread to other agents, and what is the multiplicative impact of a given intervention. So the University of Chicago is a hard place to leave because the proximity of the hospital to the main campus, the porousness of our institution is really special. And I've benefited my whole career from the opportunity to collaborate across disciplines here.